In this video, we'll be reviewing dental injections covered in chapters 12 through 16 of your Bassett text. While we review each type of injection, you can be filling out your injection guide. Not only will we be reviewing the different types of dental injections, but the nerves they anesthetize, their insertion and deposition sites, the depth and angulation the injection should be given, as well as any complications that can occur. There are two types of dental injections, a nerve block and infiltration. Nerve block injections deposit the anesthesia near a major nerve trunk. It's farther from the area being treated and usually includes multiple branches of nerves. Infiltration is the simplest and safest of the oral injections. It has a high rate of success and a wide margin of safety. These injections anesthetize a smaller area because the anesthesia is deposited near the apices of just a few teeth. It works best on the maxillary because the buccal bone all along the outside of the arch is thin and permeable, allowing anesthesia to diffuse easily through the bone to the roots of the teeth. The mandible, on the other hand, is covered with a denser cortical bone that anesthesia has a hard time diffusing through. The exception to this is the mental or chin area, where the bone is thinner. The anesthesia does a fairly efficient job infiltrating through the buccal bone, allowing anesthesia to reach the mandibular incisors. Let's take a quick review of the trigeminal nerve. It exits the skull through the foramen ovale, entering the pterygopalatine fossa, where it splits into three branches, V1, V2, and V3. For our purposes as hygienists, V2 and V3 are the only nerves that pertain to us. The maxillary nerve, V2, divides into the posterior superior alveolar nerve, which enters the maxilla at the posterior superior alveolar foramen. It continues anteriorly, dividing into the middle superior alveolar nerve, the anterior superior alveolar nerve, and the infraorbital nerve, finally exiting below the orbit through the infraorbital foramen. Additional branches are the greater palatine nerve that exits from the greater palatine foramen and the nasopalatine nerve that exits from the incisive foramen. There's also the lesser palatine nerve that exits through the lesser palatine foramen, but again, that's a nerve that doesn't really pertain to us as hygienists. This is just another really good picture that shows the different divisions of the maxillary nerve to help you better understand how this area is innervated. The mandibular nerve, V3, divides into the lingual nerve that innervates the lingual tissue and the tongue, the buccal nerve that crosses over the mandible behind the retromolar area, innervating the buccal gingiva and cheek, and the inferior alveolar nerve. The inferior alveolar nerve enters the mandible through the mandibular foramen on the lingual side of the ramus. It further divides at the mental foramen into the incisive nerve that remains in the bone innervating the anterior teeth, and the mental nerve that exits the mandible innervating the soft tissue around the chin. And again, this is another really good picture here that shows how each one of these branches is distributed around the mandible. Things to remember for just about any injection. Retract the lip outwards, opening up the vestibule. This will increase visibility and improve access as well as patient comfort. Pulling the tissue taut prior to the insertion of your needle doesn't hurt as much for the patient. For most injections where bone contact is possible or desired, be sure that the bevel of the needle is directed towards the bone. If bone is contacted when the bevel is pointed away from the bone, barbing of the needle tip might occur. This will make the removal of the needle and any subsequent injections more painful, like pulling a tiny fish hook out of your mouth. Ouch. Never insert a needle to its hub. If the needle were to break off, then there's no way to grab that needle and pull it out. So you should always have a centimeter or so of the needle above the gum line. Confirm anesthesia. Just like with nitrous, ask your patient what they're feeling. Maxillary injections will be less profound than mandibular ones, so they may say that they don't feel much. When giving an inferior alveolar injection, the whole side of their mandible will be numb, including their tongue all the way to the midline. You can perform a second confirmation of anesthesia by pressing the gingiva in the affected area with an instrument and asking if they feel anything. For unsuccessful injections, those that don't anesthetize as expected, reevaluate where the problem might have occurred by visualizing the bony anatomy and the path you took with your needle. Palpate the area with your finger to feel for any unusual morphology. Maybe there was some exostosis that prevented adequate diffusion into the bone. Check the radiographs. Maybe the foramen you were aiming for was in a slightly different location than where you were expecting. Maybe teeth have drifted, moving landmarks that you were relying on, resulting in a deposition being too far away from where the target was. It may be necessary to adjust the angulation, move farther up the nerve branch, or do a supplemental injection. Reassess your syringe angulation and your depths of penetration. Reconsider the volume of the solution that you use. Perhaps you didn't use enough. We'll begin reviewing the infiltration injection. Infiltration refers to the act of the anesthetic solution diffusing or infiltrating through the buccal bone to reach and anesthetize the nerves that are entering each of the root apices. This is used when treatment is isolated to just one or two teeth. Because these injections are anesthetizing the nerve as it enters the apex of the tooth, they also anesthetize the pulp and periodontium, meaning the facial tissue, periodontal ligament, and the surrounding alveolar bone. When giving this injection, you'll use a 25-27 gauge short needle, aiming for the height of the vestibule, right above the tooth that you're wanting to anesthetize. If you're doing it on the mandibular anteriors, then you'll want to be below the teeth you're wanting to anesthetize. The needle should be parallel with the long axis of the tooth, following the slope of the buccal bone, being sure that the bevel's towards the bone. The deposition site will be slightly above the apex of the maxillary tooth and slightly below the apex of the mandibular anterior tooth. The depth depends on the location of the apex, but usually it's about 5 millimeters. There are minimal risks of complications with these injections, but they can include postoperative pain at the injection site, some edema, and rarely a hematoma. Nerve blocks differ from infiltration injections in that they're deposited farther up the nerve trunk, and they will anesthetize several teeth, usually sextants or quadrants at a time. Maxillary nerve blocks consist of the PSA, which will anesthetize the maxillary molars, with the exception of the mesiobuccal root of the first molar. The MSA anesthetizes the maxillary premolars, as well as the mesiobuccal root of the first molar, and the ASA anesthetizes the anterior teeth on that one side. An infraorbital injection, or an IO, is deposited near the infraorbital foramen below the orbit of the eye and anesthetizes the premolars and anterior teeth on that one side. It's like combining the MSA and the ASA. It's a great injection in that the patient only has to receive one injection, but we won't be learning that one in this course. Often patients complain because it will anesthetize their nose and lower eyelid, and to them it feels like their eye is numb. There are 3 palatal injections. All of these can be a bit tender for the patient to get. This is because the tissue covering the hard palate's attached to the bone, and there isn't a lot of space for the anesthesia solution to go, so it just sort of is forced into the dense connective tissue that makes up the attached gingiva. All the other injections deposit the solution in loose connective tissue that displaces easily and fairly painlessly. Starting with the nasopalatine injection, this anesthetizes the nasopalatine nerve as it exits the incisive foramen right behind the 2 maxillary centrals. It's very easy to identify because it's covered by the incisive papilla. This injection will numb the soft tissue of the palate from canine to canine. The greater palatine injection anesthetizes the greater palatine nerve as it exits the greater palatine foramen. It's very efficient at numbing the soft tissue of the palate on one side of the mouth, from the first premolar to the soft palate. So between the nasopalatine and the greater palatine injection, you can numb all of the palatal tissue on that one side. The lesser palatine injection is one we don't give as hygienists, but it anesthetizes the lesser palatine nerve as it exits the lesser palatine foramen, which innervates the soft palate. This injection is used for uvulectomies. Sometimes you'll find during an EOIO that patients may not have a uvula. It's not uncommon for people to have their uvula removed as treatment for a snoring problem. Let's begin looking at the specific details for how to give each maxillary injection, beginning with the PSA nerve block. The posterior superior alveolar nerve enters the maxilla at the posterior superior alveolar foramen. This injection anesthetizes all of the maxillary molars with the exception of the mesiobuccal root of the first molar. It will also anesthetize the buccal soft tissue and the periodontium. Sitting at 9 o'clock for a towards injection and 11 o'clock for an away injection, you'll use a short 25 or 27 gauge needle. Insert it at the height of the vestibule above the second molar with the bevel towards bone. It should be at a 45-degree angle to the mid-sagittal plane as shown here. And it should be at a 45-degree angle from the occlusal plane as shown here. A good visual guide is to divide the first molar crown from the mesio-occlusal corner to the disto-gingival margin. The depth of insertion should be about 2/3 the length of a short needle. Bone should not be contacted for this injection. Aspirate twice, then deposit about 1/2 to 2/3 of a cartridge at a rate of about 1 cartridge a minute. Injection failures related to the PSA can be the anesthesia was deposited too far from the foramen. Oftentimes the syringe isn't angled backwards or inwards enough and the anesthesia doesn't make it to the foramen, or the needle isn't inserted far enough. Other reasons could be that too little solution was deposited, or if there's any inflammation or an infection in the area, the anesthetic won't work as efficiently. Inflammation or infections can change the pH of the surrounding tissue. This can have a significant effect of how well the anesthesia works. Complications can include contact with bone. If that's the case, you probably hit the maxillary tuberosity. Just withdraw a few millimeters, move laterally, and try again. If the insertion point was too far forward, you could hit the zygomatic process. If that occurs, withdraw and reassess your landmarks. Palpate a little bit to be sure where everything is, and then try again. Because of its proximity to the pterygoid plexus of veins, the PSA poses the highest risk for a hematoma. It occurs from over-inserting the needle into the pterygoid fossa. Oftentimes, the hematoma isn't suspected because the fossa is so far deep that the bruising doesn't show right away. Because of its high risk, it may be contraindicated for patients with clotting disorders. In that case, just use multiple infiltration injections instead. The middle superior alveolar nerve branches off the infraorbital branch of the maxillary nerve within the infraorbital canal. Some studies have shown that up to 50% of individuals don't have an MSA. This injection anesthetizes the maxillary premolars as well as the mesiobuccal root of the first molar. It also anesthetizes the buccal tissue and the periodontium. Sitting at 9 o'clock for a towards injection and 11 o'clock for an away injection, use a short 25 or 27 gauge needle. Insert it at the height of the vestibule above the second premolar with the bevel towards the bone. The syringe should be parallel with the long axis of the teeth with just a slight angle inward following the angle of the buccal bone. The depth of the insertion should be about 1/3 the length of a short needle, but this may vary slightly as you reach your deposition site of just above the apex of the second premolar. Bone should not be contacted for this injection. Once at the target, aspirate twice, then deposit about 1/2 to 2/3 of a cartridge at a rate of about 1 cartridge a minute. Common injection failures include depositing the anesthesia too far away from the apex of the desired tooth or not depositing enough anesthesia. Exostosis may cause inadequate diffusion of the solution into the bone. Due to the number of people who don't possess this nerve branch, it may be necessary to use alternative nerve blocks such as an infraorbital injection or supplemental infiltration injections across the premolar area. Inflammation and infection could be changing the pH of the area as well. Complications due to this injection are minimal. Occasionally, they may have postoperative pain or edema, but rarely a hematoma. The anterior superior alveolar nerve is the terminal branch of the maxillary division of the trigeminal nerve. It branches from the infraorbital nerve within the infraorbital canal a few millimeters before the infraorbital foramen. It descends through the maxilla to innervate the canine, lateral, and central incisors on its respective side. It also anesthetizes the buccal and labial soft tissue and periodontium. Sitting at 9 or 10 o'clock for either side, use a short 25 or 27 gauge needle. Insert it at the height of the vestibule, right above the canine, with the bevel towards the bone. The syringe should be parallel with the long axis of the tooth, with just a slight angle inward following the angle of the buccal bone. The depth of insertion should be about 1/3 the length of a short needle, but again, this may vary as you reach your deposition site of just above the apex of the canine. Bone should not be contacted for this injection. Once at the target site, aspirate twice, then deposit about 1/3 to 1/2 of a cartridge at a rate of about 1 cartridge a minute. Common injection failures include depositing the anesthesia too far away from the apex of the desired tooth, or again, not depositing enough anesthesia. Exocytosis, again, may hinder adequate diffusion of the solution into the bone. Inflammation and infection could be changing the pH of the area. Frequently, when working around the midline, though, you might run into what is known as cross-innervation. This is an overlapping of the terminal fibers located on the other side of the midline. The ASA nerve on the maxilla and the mental incisive nerve on the mandible. So even though you might have achieved adequate anesthesia on the one side of the midline, the nerves of the adjacent side, which are not anesthetized, may be causing the sensitivity. When this is the case, an infiltration injection over the central incisor of the quadrant you're working in should provide adequate anesthesia. Complications due to this injection are minimal. Occasionally there may be postoperative pain or edema, but again, rarely a hematoma. Moving on to the palatal injections, we'll begin with the nasopalatine nerve block. The nasopalatine nerve block provides anesthesia for the osseous and soft tissue on the palate from canine to canine. It provides bilateral anesthesia because both the right and left nasopalatine nerves pass through the incisive foramen. It's covered by the incisive papilla, making it very easy to find. Sitting at 10 o'clock for either side, use a short 25 or 27 gauge needle. Insert it with the bevel towards the bone at a 45-degree angle to the mid-sagittal plane at the widest portion of the base of the incisive papilla. The depth of insertion will only be a few millimeters until you hit bone. This is desired and necessary. Once bone is hit, back off about a millimeter. Your deposition site will be near the center of the incisive canal. Once at the target site, aspirate just once, then deposit about 1/8 of a cartridge at a rate of about 1 cartridge a minute. Even 1/8 of a cartridge is a lot. Because there's little room to accommodate the anesthesia under the tissue, greater force will be needed to advance the anesthesia through the needle. It won't take much before you notice the tissue begins to blanch or turn white. Once the blanching gets to about the size of a dime, remove the needle. The greater palatine nerve block provides anesthesia for the osseous and soft tissue on the palate from the premolar to the soft palate. The anesthesia is deposited at the greater palatine foramen located at the junction of the alveolar process of the maxilla and the palatine bone. Usually, it's apical to the second and third molar. Sitting at 10 o'clock for either side, use a short 25 or 27 gauge needle. You'll find the insertion site by palpating with a cotton tip applicator until you find a soft spongy depression. This identifies the greater palatine foramen. With the bevel towards the bone and at a 45-degree angle to the mid-sagittal plane, insert the needle just anterior to this depression. Advance slowly until the bone is contacted, then back off 1 millimeter. The depth of insertion will only be a few millimeters. Once at the target site, aspirate once, then deposit about 1/8 of a cartridge at a rate of 1 cartridge a minute. Blanching and palatal sweating around the needle are common and normal during deposition. Injection failures for both the nasopalatine and greater palatine injections can be from depositing the anesthesia too far away from the foramen. This often is the case with the greater palatine injection. Correctly identifying where the foramen is located can be tricky. Depositing inadequate volumes of anesthetic solution. Being that these injections are uncomfortable, removing the needle before enough anesthetic's been administered is common. Inadequate diffusion of the solution due to the dense tissue. Cross-intervention from the nasopalatine nerve can occur. You may have to infiltrate on the palatal side, lingual to the canine and premolar area. Complications are usually minimal with these injections. Post-procedural lesions such as herpes ulcerations aren't uncommon in the palate, but they're more frequent in the anterior region. Necrosis of the tissue is also uncommon, but it can occur more so with palatal injections than anywhere else in the mouth. These are due to the vasoconstrictor in the anesthetic. If too much anesthesia is deposited and the area goes without blood for too long, then tissue necrosis can occur and a large sore will develop. Hematomas here are usually uncommon. Oftentimes, to make these uncomfortable palatal injections more tolerable, pressure anesthesia is used. This is based on the gate control theory of pain. The gate control theory states that there are certain locations or gates in the central nervous system that when flooded with impulses from less painful stimuli will block impulses generated from more painful and subsequent stimuli. So this technique is implemented with palatal injections by applying 1 minute of firm pressure at the penetration site from a cotton tip applicator just prior to the injection. So for a nasopalatine injection, the pressure anesthesia is applied at the insertion site right next to the incisive papilla, and for the greater palatine injections, the pressure is applied at the soft spongy area that represents the greater palatine foramen. It's important to apply continuous pressure and right up until needle penetration. If the cotton tip applicator is removed too early, then the nerve resets itself and it's like it was never done. It can be a little tricky to get the timing down, but once you have it, it's actually quite effective. Let's now take a look at the mandibular injection. The inferior alveolar nerve is the largest branch of the mandibular division. Therefore, it is thick with many core and mantle nerve bundles. Because the majority of the IA nerves are deep within dense bone, the most effective place to deposit the anesthesia is where the nerve enters the mandible at the mandibular foramen. The inferior alveolar nerve block, or IA, is by far the most difficult injection to achieve profound anesthesia. But when it's successful, it will get all the dentition in that quadrant, the periosteum, the buccal mucosa from the premolars to the midline, the floor of the mouth, and half the tongue. The difficulty of this injection is caused by several factors. The deposition site is much farther up the nerve trunk than any of the other intraoral injections, so therefore the nerve is thicker. If you remember, the anesthesia has to diffuse through many layers of tissue barriers before it gets to the core fibers. Also, the descending inferior alveolar nerve is buried among many other tissue structures such as muscles, arteries, veins, connective tissue, and other nerves. And this area has the most anatomical variations among people. It's a tough nerve to get to. Important landmarks that need to be identified are the pterygomandibular raphe. This is a visual landmark. It's the attachment of the buccinator muscle to the pharynx. The mucosa that overlies the pterygomandibular raphe is the pterygomandibular fold. This landmark identifies the insertion point, which will be made slightly lateral to the raphe. The prominence of the raphe can vary significantly among individuals. It's best noticeable when the patient opens their mouths wide. The coronoid notch on the anterior border of the ramus of the mandible will determine the height of the injection. The ideal height is slightly higher than the deepest concavity of this notch. If the injection is too far below the notch, the deposition may be below the mandibular foramen, and then anesthesia will be best at minimal. The mandibular foramen, too, can vary among individuals, either higher or lower. The third landmark is the internal oblique ridge. You see it on your bite wing x-rays a lot. It's on the medial surface of the mandible, close to the molars, and continuing posteriorly. This landmark represents the lateral extent of your injection. By penetrating medial to this landmark, premature contact with the ramus can be avoided. If it does occur, it'll occur just millimeters after insertion. It can be painful and barb the needle as well. I'm going to briefly give you an overview of how to administer this complicated injection. It's impossible to learn it without doing it, but this will familiarize you with the sequence. The best place to sit is at 9 or 10 o'clock for a towards injection and 11 or 12 o'clock for an away injection. A long 25 and 27 gauge needle would be used for this injection. Begin by palpating the landmarks. Have the patient open wide and using a finger from your opposing and retracting hand, retract the cheek. Feel for the deepest portion of that coronoid notch. Slide your finger and thumb into the triangular space of the retromolar area created by the inter and external oblique ridge, and then maintain this position. Position and angle the syringe barrel parallel to the occlusal plane of the teeth on the same side. Be sure that the bevel is towards the bone. Be very careful to avoid a needle stick because you'll be very close to your thumb or finger here. Insert the needle lateral to the pterygomandibular raphe and slightly higher than the deepest portion of the coronoid notch. Insert to the depth of 1/2 the length of a long needle, then stop. Swing the syringe to the premolar region of the opposite side of the arch. Continue inserting until resistance is met or you hit bone. For this injection, you want to hit bone. Once you do, back off 1 millimeter. When finished inserting, about 2/3 to 3/4 of the length of a long needle will be placed. The deposition site is just above the mandibular foramen. This way the anesthesia can reach the nerve before it enters the mandible. So once you have hit bone, you'll aspirate 3 times. Aspirate once, negative. Make a quarter turn and aspirate again, negative. Make another quarter turn and aspirate again. If all of the aspirations are negative, then begin depositing the anesthesia at the rate of 1 cartridge per 1 to 2 minutes. As far as injection failures, remember that the IA is the most difficult to be successful and has the highest failure rate. This is often due not necessarily to operator error, but to the greater anatomical variations of the mandible. Some people's mandibular foramen just aren't where you think they should be. Deeper needle penetrations can make some clinicians a little apprehensive, so then they don't go in as far as they should. Depositing the anesthetic either too shallow or too medial, too posterior, or especially too inferior or below the mandibular foramen. Due to the many anatomical structures that the needle has to work around, a needle can be deflected in a different location. Many times it'll be deflected medially, so it's important to have the bevel towards the bone to avoid this. The IA also has the most complications as well. It has a 10 to 15% positive aspiration rate because of the high vascular nature in that area. Post-injection muscle soreness is quite common. Trismus can occur, which is a limitation of the mandibular movement due to the injury of the muscle fibers during injection. Paresthesia can occur, but it's usually transient. Facial nerve paralysis. If a person's facial nerve is more anterior than is typical, or if the anesthesia was deposited well posterior to the mandibular foramen, then the facial nerve can become anesthetized. This results in drooping of the upper lip and an inability to close the eyelid on the injected side. Luckily, it just lasts as long as the anesthetic is working, so usually just for a couple hours. Self-injury such as biting the tongue or the cheek or the lip is common, especially among children, so it's important to counsel the parents to watch out for that. The mental and incisive nerve block is a much easier injection to give and be successful. The mental and incisive nerves are the terminal branches of the inferior alveolar nerve. The incisive nerve stays in the mandibular bone and innervates the mandibular premolars and anterior teeth, and the mental nerve exits at the mental foramen, innervating the buccal and labial mucosa anterior to the mental foramen. For the sake of injections, we'll refer to it as the mental nerve block, but in reality, it's getting the incisive nerve also. This mental injection anesthetizes the mandibular premolars, the canines, and the incisors up to the midline. It also anesthetizes the labial soft tissue and the periodontium. Setting at 12 o'clock for either the right or left injections, use a short 25 or 27 gauge needle. Insert it at the depth of the vestibule directly below the contact of both premolars with the bevel towards the bone. This is where the mental foramen is found. The syringe should be parallel with the long axis of the teeth with just a slight angle inward following the angle of the buccal bone. The depth of insertion should be about 1/3 the length of a short needle, but this may vary slightly as you reach your deposition site of just below the apices of the premolars. Bone should not be contacted for this injection. If you do, then you're too close to the mandible and you need to reposition more towards the vestibule. Once at the target site, aspirate twice, then deposit about 1/2 to 2/3 of a cartridge at a rate of 1 cartridge a minute. Once the injection is finished, massage the area to work the anesthetic into the mental foramen. Like the infraorbital nerve block, the anesthesia has to travel up into the foramen to reach the nerves inside. This is a highly successful injection, but if failure does occur, it could be from being in the wrong area, or there could be some cross-innervation from a neighboring nerve. An especially small mental foramen might prevent the anesthesia from entering the foramen to anesthetize the incisive nerve. Complications are infrequent, but bleeding, hematomas, and postoperative discomfort is always possible with every injection. The buccal nerve is a terminal branch of the mandibular nerve. It crosses the coronoid notch of the ramus at the level of the occlusal plane. It innervates the buccal mucosa and gingiva of the mandibular molars and occasionally of the premolars. This injection anesthetizes these same structures. No pulpal anesthesia is provided here. Setting at 9 o'clock for a toward injection and 11 o'clock for an away injection, use a long 25 or 27 gauge needle. With the syringe parallel to the occlusal plane, insert in the buccal mucosa at the height of the occlusal plane, just distal and buccal to the most posterior molar. The depth of insertion should be about 5 millimeters. Have the bevel towards the bone, and no bone contact should occur. Once at the target site, which is just inside the buccal mucosa, aspirate twice, then deposit about 1/4 to 1/3 of a cartridge at a rate of about a cartridge a minute. Injection failures for this are rare. This injection is often done after an inferior alveolar injection, so if not enough solution was reserved for an adequate buccal injection, then there just may not have been enough anesthesia deposited. Complications are also rare, but can include bleeding, hematoma, or postoperative discomfort.